talk about wheat and celiac and sensitivity, especially in Egypt, is not very easy. The patient will come out with two outcomes that he doesn't like, which he doesn't like. First, there's no prescription sheet because there's no medication. And second, you will stop them from having what is in Egypt is cardinal to admission, which is the brain issue. It's a very sensitive subject. What this lecture is not going to talk about is celiac disease. So, as we know, celiac disease is a chronic small intestinal immune-mediated enteropathy, and it's precipitated by the exposure to gluten. Other terms that we should not use because they're out of fashion now are the celiac sprue, the sprue, the gluten intolerance, and the gluten-sensitive enteropathy. They're not recommended anymore. If you look at this lady, she's a 26-year-old female that doesn't have any past medical history and with a 3-year history of abdominal discomfort with bloating, gas, constipation, and she has sought some advice from a friend and went on a gluten-free diet and had a lot of symptom improvement. The symptoms included headache, fatigue, 15 pounds of weight loss, about 7 kilograms, in the last 6 months. Serology showed negative anti-enzyme, negative TGIA, negative high anti-gliadin 37, normal anti-gliadin IgA, and a normal range IgE of 14.3. And when she had an allergy test, it showed to be below detectable limits. But she did have a good response to a gluten-free diet. She had an endoscopy, which was unremarkable, whether macroscopically or microscopically. So maybe she's gluten intolerant. That's a picture of a woman having pasta on the floor. So wheat. What is wrong with wheat? What's wrong with wheat? So wheat was first consumed by human beings 17,000 years ago and has been cultivated 10,000 years ago. In America, for example, they consume 134 pounds of wheat per citizen per year. The wheat journey in general is cultivated in the Levant, which is Syria and Iraq, 8,000 BC. 6,500 BC, it was in the Greek area, in Cyprus, and India. We started consuming wheat 6,000 years BC. Then Germany and Spain, England, Scandinavia, then China, and we produced the first bread 1350 BC. The anatomy of the wheat kernel itself is interesting because this is the bran bit. We keep telling patients to eat bran, and we don't know what bran is exactly. So this is the sumbula. This is the bran part, the outer part, the hard part. This is the wheat germ, which is known to have a lot of vitamins and have a lot of anti-cancer functions. And this is the endosperm. The gluten is a complex group of alcohol-soluble polymerides, but water-insoluble, that make up about half of the protein in the human brain. But what is gluten? It's a matrix. It's formed of a few proteins, mainly the gliadin and the glutenin. And other sort of grains will have similar immunogenic properties, like in rye, like in barley, and other grains, which will cause the same effect. So what are the claims about wheat and gluten? So there's a claim that people cannot tolerate wheat and gluten because we don't have the enzymes to digest it. But the vast majority of people, 93% of the population worldwide, can digest wheat and gluten. Many people have allergies and intolerances to gluten, but 0.5 to 6% of the world population has improved only that to have true allergy to wheat. Going gluten-free will will cure most common-day illnesses as produced by most celebrities in the world. They all go gluten-free. Obesity, diabetes, heart disease are caused by a variety of factors and not a single food type or food diet. So it does not really cure anything apart from wheat sensitivity. Very few people actually have celiac disease. It's between 0.5 to 6%, and even a smaller number has wheat allergy. But the presumption of the public or the presumption of the GPs is that mostly 35% of people have food allergy, and 35% of people grow on a diet of some form of food restriction. And when actually tested, it goes down to 3.5%. So therefore, decrease when you actually look for evidence of a food allergy. But celiac disease is the tip of the iceberg. This slide used to be celiac disease and latent celiac disease in the past. And now there's almost nothing called latent celiac disease, it's just a gluten sensitivity form. So how do we know this? Because people tell us, because the clinical results tell us, because the blood tests tell us, and the medical studies and evidence-based medicine tell us. So what's the free market tell us? The free market tells us that in the University of Chicago Celiac Disease Center states that 97% of celiacs have not been diagnosed yet. So there's a huge amount of celiacs in the world that go unnoticed. So talking about non-celiac gluten sensitivity, what is it exactly? It's a clinical entity, it's a disease. It's induced by the ingestion of gluten, leads to intestinal and extra-intestinal symptoms, and they do resolve once the gluten-containing foodstuff is removed. But this is provided both celiac disease and wheat allergy have to do with that. So it's new. Very new, but it's been around since 1980. The prevalence is actually unknown because not most people think about it, but it's probably higher than celiac disease itself. And different studies done in the US have found its prevalence from 0.5% to 30%. And of course, it's about self-referral and GP testing. There's no specific criteria or validated test for its diagnosis. It requires a lot of double-blind challenge and research, but it's reported a lot in association with other allergic diseases. The repeated mechanisms, a few. There's a theory about the elevated AGA, the anti-gluten antibody, mainly the IgA type. Sometimes the IgG, up to 50% of cases will have a high IgG-AGA. There's no specific HLA association, which rules out the true celiacs. Some studies suggest that the gluten may activate the innate immune system, causing increased permeability, may cause inflammation, most like a leaky gut. But the problem is a lot of research has come out as well to negate that. So the decision is still out, the verdict is still out about the mechanism itself. So what does a celiac, what does a gluten patient feel? A gluten patient usually has diarrhea, can go up to fainting and dizziness, fever, itchy, rash, hives, nausea, stomach pain, vomiting, and the cardinal symptom of bloating. Additional symptoms, there are around 133 characterized symptoms for non-celiac. But the most important, they can go up to seizures, numbness in hands and feet, nosebleed, muscle cramps, mouth ulcers, joint pain, itchy skin, hair loss, fatigue, anxiety, and depression. It even went as far as documented evidence saying that when children have non-celiac gluten sensitivity, they present as celiacs but without weight loss. So they do have abdominal pain, they have diarrhea, but there's no loss of weight. And bizarrely enough, it is now linked to symptoms of fatigue, autism, and attention deficit disorders in children. So basically, it's a negative celiac and a positive gluten intolerance. So the tissue glutamate antibody is negative, the biopsy is negative, the gliadin antibody is positive, whether IgA or IgG, and the total IgA is normal. So what is it? It's basically this territory between IBS and a full-blown, documented, certified, validated celiac disease. This grey zone that is probably larger in size than either side of that. So we'll go through some fairly quickly the results of some studies. So this is a study done on the small bowel mucosal inflammation in response to the gliadin without benazepril. And the conclusion, the IgA class anti-gliadin antibody positive patient with normal small bowel morphology implies that they might be gluten sensitive. Another study published in 2000 basically saying intolerance to celiac is not specific for celiac disease, and it's proven that allergy to celiac other than celiac disease should be considered even in adults. Another study in 2001, celiac disease without benazepril, the revision of the criteria called for, and followed 10 adults suspected to have celiac disease, but only minor mucosal inflammation, showed a clinical, histological, and serological recovery on a celiac diet, on a gluten-free diet. And Albert Bjork, who won the Nobel Prize in Medicine in 1937, said discovery is to see what everyone else has seen and to think what no one else has thought. So looking more into emerging new clinical patterns in the presentation of celiac disease, it was done in 2008. And it showed a review of the medical records of all patients diagnosed with celiac disease at the Children's Hospital of Wisconsin between 1986 and 2003. And it showed that patients with celiac disease usually do not present with the classic symptoms. They are more likely to be asymptomatic. So let's look at some evidence on the signs and symptoms. So in 2006, daily treatment, large treatment of gluten neuropathy showed that the effect of a gluten-free diet in patients with idiopathic sensory motor axonal neuropathy and circulating antibodies. A total of 35 patients, 25 were put on a gluten-free diet and 10 were on control, and there was evidence of improvement in the treatment group and the deterioration of the control group. Another one in 2007 about the neuropathy associated with the gluten sensitivity. 4 out of 7 patients not on immunosuppressive treatment showed marked clinical improvement on a gluten-free diet. Again, there's a study published in 2004 about 3 patients that were thought to be systemic lupus, but discovered after years that they were gluten sensitive, and it showed that the presence of an enteropathy is no longer requisite to the diagnosis of the gluten sensitivity, or we should really think out of the box when the data do not end up right. Again, there's actually treatment of a gluten ataxia. So this patient had an ataxia that actually related to gluten, and it accounts for 40% of the idiopathic sporadic ataxia, and it does respond to a strict gluten-free diet even in the absence of an enteropathy. So there's also antibodies against food other than gluten. So the same way we can look at antibodies to wheat, barley, rye, and spelt. They're typically IgG antibodies, and if anti-gliadin antibodies will be up, they will probably be up as well. So this is a study on the clinical significance of food-specific IgE, IgG4 in food-specific atopic dermatitis, and again, it does show that they did a double-blind placebo-controlled food challenge test, and it was, by definition, so that the average mean of the IgE and IgG4 levels were high and the patients responding positively to the test and lower in the negative ones. Again, another study about the IgG4 antibody gliadin exclusion diet with symptoms improvement with IBS. Again, a similar one. But this one was showing that there was no pure allergy, but there were IgG4 antibodies to common foods, and when stopped, the symptoms of IBS improved. This was another big study in 2004 about food elimination in IBS, had 150 patients. They randomized for 3 months on a diet, excluding all foods they have been raised IgG antibodies to, or another group that had a sham diet, but to which none of them they had antibodies, and it showed a resolution of their clinical symptoms, which showed that the compliant patients will experience significant benefit. Another study showed the therapeutic effect of eliminating allergic foods, and it showed that normal immune reaction mediated by the IgG antibodies coexisted in patients with IBS. So there are also other aspects to the wheat, which is the non-gluten wheat part, which you should not react to the gluten, but you can react to the wheat itself. I'll pass by this one. So we go to FODMAP. So what's FODMAP? FODMAP is the fermentable oligosaccharides and disaccharides and monosaccharides, and the polymers, which are the artificial sweeteners. And most grains contain the wheat starch as well as FODMAP. So when you put the patient on a FODMAP diet, you can almost go halfway gluten-free. So if you have wheat ingestion, you can have a gluten-mediated reaction, or you can have a poorly absorbed carbohydrate, or you can have just a nocebo effect. So a gluten-mediated will either lead to an autopermeability, or an immune activation, or a low-grade inflammation leads to GI symptoms. The poorly absorbed carbohydrates can produce excess fructans, more gas, and more short-chain fatty acids. More fermentation happens, microbiome changes, and leads to GI symptoms. So wheat can affect you either way. So how do we evaluate? History is very important. Lactose intolerance has to be excluded. Tests for small intestine bacterial overgrowth, skin testing, diary, do all the basic blood tests, CBC, eosinophilic count, immunoglobulins, specific antibodies, which as well as serum IgG to food is no longer accepted as a diagnosis, and seek Gastropharmacology. Now, what to eat and not to eat is always a question. Studies have proven that patients, when they come to gastroenterology, they expect to have explicit advice on what to eat and what not to eat. And the marketing of food promoting a potential health benefit is becoming very common in the West. The gluten-free market in the States now is more than 15 billion annual sales last year. The portion of the households using the gluten-free product has increased from 5% to 11%. And a lot of the common brands have a gluten-free version. So the dietary response is diagnostic, and the placebo response in IBS for up to 70%. But there are potential mechanisms, including psychological, and again, the overlap between FODMAP and gluten. When we look at the adverse reaction, in wheat allergy, pure wheat allergy, it's immediate with varying dose, and there's no neurological or psychological issues, no anemia with specific IgE. In celiac disease, it's delayed. The extra-standard neurological and psychological issues vary. There is anemia and there's antibodies. In non-celiac gluten sensitivity, again, the dose varies. There is neurological and psychological issues. There's no anemia and only the AGA. Sometimes the wheat IgG. In wheat starch intolerance, it varies, it builds up post-ingestion, and there's no extra standard typical issues, and typically there's no biochemical changes. We know that gluten causes symptoms in IBS, and you can see that overall symptoms are higher when gluten is involved, the bloating is much higher, and the pain mark is higher. But this is a very interesting study. This basically, they've got 37 patients with no three criteria having IBS. They gave them a FODMAP diet and a gluten-free diet, and the symptoms improved remarkably. And then they reintroduced the gluten while still on FODMAP, and the symptoms did not come back. So there is a big overlap now between the FODMAP symptomatology and the symptomatology and the gluten sensitivity. So foods to avoid are, as we know, the barley, the beer, the bread, cereals, couscous, any flour, any rice, any spelt. Extra stuff, something like the vegetable protein, the soy sauce, the modified food starch. Oats themselves do not contain gluten, but only if you buy them from a mill or from local. If you buy them from the supermarket, they will have gluten, so that's very important. There are lots of stuff that have potential sources of gluten, even cheese, french fries, crisps, rice mixes, flavored nuts, the whole lot. And things have hidden gluten. So the imitation seafood that you buy at the freezer section of the supermarket has gluten. The licorice has gluten. The cold cuts all have gluten. And flavored chips and nuts. Things to avoid: certain cosmetics will have gluten, and this is for very sensitive patients. Certain medications will have gluten. Certain soaps and shampoos will have gluten. Usually the powder that relates to blood will have a gluten element in the form of certain flour, and the stamps and the envelopes when you mix them, sometimes the glue has gluten. So all of this you have to be aware in very sensitive patients. This is sort of a very quick algorithm. The patient has symptoms that are responsive to the gluten-free diet. If we've done serology, it's negative. No enteropathy is probably NCGS. If you have enteropathy, go for a biopsy. It could be a seronegative celiac. If there is no serology negative, then do HLA typing. If the serology is positive with a borderline, then do HLA typing. If it's positive, go for a biopsy. If it's negative, then treat as non-celiac. If it's positive serology, positive biopsy, then it's celiac. If it's normal MARSH 1, it's potential, this would be MARSH. So it's MARSH 2 or 3, it is celiac. Just a repetition of the last one, just to put them all together. In celiac disease, the serology is positive, while weak allergy is negative, and in NCGS is negative. The urine biopsy will have to be normal or normal, and the IgE is negative here, but it's positive for weak allergy and negative with non-celiac. Last time about the healthiness of the gluten-free diet, people think that it is healthy. It's not healthy because they have a lot of fat, sugar, and calories. The patients actually gain weight when they go on a gluten-free diet. There's a lot of B12 and folate and iron, either the fortification of the cereal or the B12 and folate in the wheat germ or in the grain itself. So people lose this if they don't take any supplementation. Again, they lose a lot of fiber. A typical gluten-free diet will have 6 grams of fiber in it daily, which will lead to constipation and articular disease. The regular US diet in general is between 12 and 16, but the recommendation is between 25 and 38. And the FDA did produce in 2007, and it's been updated in 2014, that a gluten-free label product should have less than 20 milligrams per kilogram gluten in it. The last slide is basically a summary, time interval from the gluten exposure to the symptoms. Celiac disease weeks, and non-celiac hours to days, weak allergy minutes to hours. Pathogenesis in celiac disease is an adaptive one, and non-celiac is an innate form of activation of immunity, and weak allergy is allergic. There's HLA association with celiac disease, not level 2. Autoantibodies are present in celiac disease, variable in non-celiac, and absent in weak allergy. Enteropathy is always present in celiac, it's absent, but sometimes you have enteropathy of lymphocytes, and it's absent, but you have eosinophils. Symptoms, it's standard and extra, and standard with all 3. The complications, of course, are multiple comorbidities and long-term complications in celiac, less involved just comorbidities in non-celiac, but in weak allergy, there are no comorbidities, and sometimes